I would like to welcome you to this podcast, which will discuss an interesting article being published in the September 2017 issue of Radiology entitled High-Intensity Focused Ultrasound for the Treatment of Symptomatic Benign Thyroid Nodules, Prospective Study. I am Dr. David Madoff, the Deputy Editor of Radiology for Interventional Radiology, and I am joined today by Dr. Brian Lang, who is Clinical Associate Professor and Chief of the Division of Endocrine Surgery in the Department of Surgery at the University of Hong Kong Queen Mary Hospital in Hong Kong, China. He is the lead author on this study, and we just have a number of questions we would like him to address. So welcome, Dr. Lang.
Thank you very much. It's a pleasure to be here.
Thanks. So just to start off, can you review with our audience the clinical issues surrounding the management of benign thyroid nodules? When should intervention be considered? And what are the standard methods used to treat these nodules?
All right. Well, as we all know, thyroid nodules, benign ones, are very common in our population. And the majority of them don't need any treatment. But we know that about 10% of nodules they do get big over time. And for those that are either size more than 4 cm in diameter, or those who are causing symptoms like obstructive symptoms or pressure symptoms, in this situation, then surgery is generally indicated. And as a surgeon, this is a very common problem for me. And that's the reason for to look at. But because surgery has risks, and we try to look at less invasive way of treating nodules. So we try to preserve those who have benign problems with less invasive options. And I think high-intensity focused ultrasound is one minimum invasive option for treatment of benign thyroid nodules.
Okay, thanks. So there are now many ablative technologies available, including RFA, microwave ablation, laser ablation, chemical ablation, cryoablation, SBRT, HIFU, which you've already alluded to, and irreversible electroporation. So many of these technologies have already been used to successfully treat benign thyroid nodules. Why was HIFU specifically chosen for your study?
I think high-intensity focused ultrasound is an attractive option for patients generally, because most of these patients are females. Obviously, for other techniques such as radiofrequency ablation or laser ablation or other ablation techniques, they only need a needle to be inserted through the skin into the nodule, and that's very minimum invasive. But nevertheless, you still need to puncture the skin. But what HIFU or high-intensity focused ultrasound can do is it can ablate an area without ever puncturing the skin, and I think that is an attractive way of treating nodules. Most of our patients who come in for treatment, they actually don't need to change. They just wear the normal clothes. They come into our treatment room, have the treatment, and then they go home, within hours after treatment. And so I think for me, that is probably the least invasive way of treating nodules. And also, as you're aware, there are, of course, many publications on radiofrequency ablation, laser ablation, but there's been very few studies on high-intensity focused ultrasound, and that's the reason why in our centers we really want to focus on this area. Just for your information, we have been treating high-intensity focused ultrasound liver lesions as well as uterine lesions. So this is not new for us. The liver lesions we have been treating for over 10 years. I don't do it personally, but my capillary colleagues, they do the liver ablation. And for me, I do the thyroid ablation because this is part of the endocrine surgery. And some of my breast colleagues are using the same machines for the breast lesions. So this is what we like to do over here. That's why we're doing it.
Well, thanks. Well, can you just explain the technology and the mechanisms of action of HIFU, since many in our audience may not be all that familiar?
Right. Well, put it in very simple terms. Basically, it's about focusing an ultrasound beam into a very small focal area underneath the skin. The depth of treatment it's usually around 1 to 2 cm. If it's too close to skin, then you worry about burning the skin. And the wavelength of the treatment wave is obviously a low frequency transmission. It's an ultrasound guided treatment, so it's real time imaging, focusing an area. And so for a nodule around 3 cm, the machine actually can divide the nodules into different subunits, and the machine automatically ablate the area. As long as you achieve a certain temperature change around 55 to 65 degree centigrade, then you will have irreversible tissue damage. And through that damage, and over time, the nodule shrinks. It's very similar to other ablation techniques, I suppose.
Okay, thanks. So for this particular study, what was your hypothesis, and what previous work led to the hypothesis?
The hypothesis was that, previous studies have shown that ablation would shrink the nodule. So it's not surprising that applying for HIFU, the nodule will shrink. What we're trying to show is that not only the nodule shrinks, but patients feel better. I think that is feel better, and the quality of life will improve as a result of the shrinkage. And I think, and in our study, we had 2 groups of patients, although not randomized. One group had the HIFU ablation, the other group just has surveillance over a 12 months period. And as expected, we found that those who had ablation, the symptom score improved relative to the controls, and also the quality of life also improved. So apart from the shrinkage that we got from the ablation, physical shrinkage, there was also a symptom improvement, as well as a quality of life improvement.
So how were patients actually selected for participation in your study, and what were the symptoms, laboratory studies, and imaging criteria used in the selection process?
Right. Patients were, well, first of all, they need to be benign in nature. So we would do a fine needle aspiration before at the first assessment to see if they are benign nodules. That is Bethesda 2 on cytology. And also these patients are symptomatic, which means that they complaining of either pressure or some sort of choking sensation. We asked them. And also patients who didn't want surgery. So these are the patients who were reluctant for surgery that we would offer ablation or observation. And it's up to them to choose. And over that period of time, we had 22 patients who desired to have treatment, and 22 patients who desire not to have treatment. And we just follow them up through the 12 months. And the results are showing on in our papers.
So was there any specific laboratory values that you were looking for, any imaging findings that would make one be more likely to do HIFU as opposed to any other kind of therapy?
Okay. Imaging-wise, apart from the cytology, of course, I think the nodules needs to have a low suspicion pattern, which means that they are either spongiform in consistency, and also they have to be well circumscribed, no suspicious features or malignancy that will consider for ablation. answer the question?
Yes, that was very good. Thanks. So just to, I guess you had already...
In terms of laboratory, in terms of blood tests, all the patients has to be euthyroid. That means the thyroid function has to be within the normal range.
Okay. So in terms of, you had basically given a brief overview of your results, but can you be a little more specific in what was actually found in terms of your results?
Okay. Specifically, I think in terms of nodule shrinkage, the median, if I remember correctly, the shrinkage was around 70% in volume as compared to the baseline, and also we found the symptoms in terms of pressure symptoms improved, and also the physical component of the health-related quality of life also improved as from baseline as compared to the controls.
So in terms of quality of life measures, what specifically was evaluated?
We did the standard quality of life questionnaires. They filled in before treatment and 6 months and 12 months after treatment, and we compared the values of the baseline with, and we found the component improvement were mostly the physical component rather than the emotional component. It was the questionnaire was the, if I remember correctly, was the SF short form.
So I guess I was, when reading your manuscript or reading your article, I looked at a lot of the symptoms such as pressure. How do patients respond to, what exactly kind of pressure are they feeling?
Number of, specifically they were either they had, before treatment they had symptoms when they lie flat, they feel there was pressure on the neck when they lie flat, or sometimes when they try to swallow fluids, occasionally they have fluid regurgitating out, so kind of choking, kind of. But it's intermittent, it's occasional, not always.
So in patients that had more than one nodule, because that I suppose often happens, how did you determine which nodule to actually treat?
That's a very good question.
Only one nodule was treated.
Yeah, I think if I remember correctly, about half our patients had dominant nodule in a multinodular goiter. So we would normally treat the dominant nodule in terms of we think the dominant nodule would probably have caused the most symptoms, and that's how we select that kind of patients.
Okay, so given that HIFU requires extreme precision, was this study performed under general anesthesia or moderate sedation? And to that end, how long do these HIFU sessions typically last?
We didn't use general anesthesia. We use moderate IV sedation. The patients had a bit of pain. It was so they weren't absolutely pain-free. We asked about pain during treatment, and most of them had pain, but the pain was tolerable. So in our series, none of them were not able to complete treatment because of pain, and so it wasn't a general anesthesia. The kind of medicine we give was IV pethidine and also diazepam, which is a benzodiazepine. We found that the analgesia was more important, so we give a high dose of analgesia. Sedation, we didn't want to give too much because that would affect the respiration. One of the problems is if you give too much sedation is patients tend to have a more heavier breathing, and that could cause movement of the thyroid, and that makes the treatment difficult. And so the sedation is the analgesia and the sedation is pretty tricky. It takes time to get the right balance, I think. Typically the treatment would takes around 45 to an hour, depending on the size of the nodule. So for most of our nodules, around 3 to 4 cm, it will take about 45 minutes usually.
Okay, great. So with regards to procedural safety, what complications occurred during the study, and what are the potential complications that can result?
In our series, about half of our patients had some sort of redness, some swelling in the ablation site. And that's not uncommon because as the energy goes through the skin into the nodule, the skin and the subcutaneous tissue and muscle actually absorb some of the energy. And we think that's the reason why you have neck swelling, at least for the first few days. And that's why usually we apply ice packing for the first few days for the first few hours. And after they go home, they can also apply ice packing. And we think that helps with the swelling. But none of them had any skin burn. We didn't have any body skin burn. Potentially, they could have vocal cord palsy because the pharyngeal nerve, which controls the vocal cords, actually lies along the tracheoesophageal groove. And so if the nodule is very close, or part of it is very close to the tracheoesophageal groove, it's possible that you can get damage of the recurrent nerve and causing hoarseness of voice or vocal cord palsy.
So how difficult is it to identify the parathyroid gland, being that you're kind of in the same region?
Yes, it's almost impossible because a normal parathyroid gland, you will not see it on ultrasound. For an abnormal one, yes, of course you will see it, but for a normal one, you don't see it. But fortunately, we have 4 parathyroid glands, and so it's pretty difficult to damage all 4 parathyroid glands to cause hypocalcemia.
Okay, great. So your study compared HIFU to active surveillance, but not to any other ablative technology. How would you think that HIFU would have compared to other percutaneous methods that have already been tried?
I think in terms of delivery of energy, actually the radiofrequency ablation and laser ablation and other ablation technique would be more efficient in terms of, because the energy would bypass the skin and the deep tissue into the nodule, and so that's why the treatment time would be much shorter than, say, high-intensity focused ultrasound. If you look at literature, the treatment time for a similar size nodule by radiofrequency ablation or laser ablation, it takes roughly 15 to 20 minutes, whereas for high-intensity focused ultrasound, it takes about an hour. So it's almost a double or a triple time difference. But mostly that's because the machine at the moment is very safe. It try to cool the skin. So actually the treatment time it's quite short. But in between the pulses, there are quite a long cooling time period, and that's why the entire treatment time is actually long. But the actual pulses is not very long. I suppose with the update on the software, probably they can improve on the treatment time. I'm quite confident that we can shorten the treatment time for by about half. If we can shorten the cooling period.
Okay, thanks. So what were the limitations of your study?
Well, I think firstly, it's not a randomized study. So as you will see if you look at the baseline comparison between the 2 groups of patients, obviously those who had bigger nodules would tend to get treated, while those who have smaller nodule would opt for surveillance. I think it's difficult to do a randomized study because patients who are offered this treatment would tend to go to have the treatment rather than to observe and do nothing. At least that's my experience so far with patients. But nevertheless, I think this is one of the bias, and this may cause this may, affect the outcomes of the study, because obviously those who get treated would like the treatment to help them, and so maybe that's maybe an explanation why the quality of life improve as well. I think the non-randomization is one of the shortcomings of the study. The study is relatively small, I must say. It's only only 44 patients and so 22 patients in each group. Although we did do a power calculation, and it seems that 22 patients were enough to achieve the power for the study. But nevertheless, a bigger study or even a multi-center study would be more convincing, I would say, because the technology at the moment is done by very few centers, and we are just one of them. And it would be nice to have a bigger multi-center study and to see if we can repeat the same results.
And I suppose, as we already alluded to, there was not really a comparison to any other ablative technology.
Yes.
But that's not necessarily a limitation. It's just an observation that maybe future studies would be appropriate. So to that end,
I must say that it's difficult for one center to do to learn different techniques and try to do it.
Exactly. So based on your study, what are the next steps now being done by your group to advance the understanding of this minimally invasive therapy for thyroid nodules?
I think one of the big areas is that if you look at the results, about 20% of nodules actually don't shrink enough in the 6-12 months. And we don't know exactly why that's the reason. And we try to, obviously, since this study, we have done about 120 treatments actually, 150 treatments actually, and we try to collect data to see, to look at whether it's a particular kind of nodule or whether it's a position or the power we use, or any other things that might predict, who would respond well to this treatment or who will not respond well to this treatment. I think that's an important information for patients to know, so that for some patients we can select them for this technology, and for others that may be less responsive, maybe they should offer other thermoablation or even surgery.
Well, great. So, Dr. Lang, I would like to thank you for joining me today on this podcast to discuss your group's clinical work comparing HIFU to active surveillance for the management of symptomatic benign thyroid nodules. I definitely thought the discussion was very insightful and should give our viewers a good platform to understand the use of this exciting technology to treat symptomatic benign thyroid nodules, as well as potentially other solid lesions. We are looking forward to seeing your group's future work. Thank you again.
Thank you very much. Thank you.